Good evening and welcome to everyone joining us this evening. Tonight's program is part of HCPLive's State of the Science Summit in Psychiatry, focused on the clinical and practical considerations for addressing challenges in depression treatment. My name is Melissa Kaplan, and I am an Executive Director on the Global Ambassador Strategies team at MJH Sciences. MJH Sciences is the parent organization for HCPLive. HCPLive would like to thank Janssen for supporting tonight's program. Before I turn it over to Dr. Ryan Wakim, our chair for tonight's event, I do have a few housekeeping notes to review with everyone. There is a Q&A box on the bottom of your screen. Please type your first and last name, including your institution, so we know who is in attendance tonight. Please also use this box to ask a question. When you do have that question, please go ahead and type it in the box and they will be addressed during the Q&A sessions. At the end of the program, there will be a drawing for two $150 gift cards for those who pre-registered and attended. Make sure to stay until the end of the program for that wheel spin to see if you win. There will also be an opportunity to receive a $50 Grubhub credit to those who pre-registered and our healthcare providers who attend until the end of tonight's program. And you must fill out our post-event survey that will be emailed to you after the program. To qualify for the Grubhub incentive, please answer each survey question. And if you would please be thorough in your responses, we'd appreciate it. Once issued, there is an expiration date on this incentive, and you will be limited to 3 Grubhub credits per quarter. Your feedback does help us improve our virtual events programs, and it also provides valuable insights to our faculty on the program tonight. I would now like to introduce our program chair, Dr. Ryan Wakim. Dr. Wakim is the Chief Medical Officer at Transformations Care Network in Boston, Massachusetts. Thank you, Dr. Wakim, for chairing tonight's program. I will now turn it over to you.
All right. Well, thank you, Mel, for the warm introduction. I'm honored to be chairing tonight's event on a topic that's, for those of you who've heard me talk before, know that I'm incredibly passionate about and it's near and dear to my heart. I'm also honored to be able to do that alongside two kind of thought leaders in the space with me. Those two individuals include Dr. Merrideth Leggat, who is our regional interventional director, physician of ours in our New Directions mental health clinics in Western Pennsylvania. And then our colleague down in the DMV, Paul Ruberg, who also is a division leader in our interventional service line with a special focus on Spravato, like I said, over in the DC metro area for us. One of the things I think, I know that we want to impress upon you tonight as we think about the treatment landscape, the definition of TRD, and what options are available kind of for us and to us. It all really begins with, what defining TRD and what our current standard of care is. And that's the sections I'll be talking through tonight. As we look at the agenda itself, there we go. As we look at the agenda itself, again, the items here would be looking at the burden of treatment-resistant depression and defining that. We then want to look at the different treatment options. This will first include a little subsection around one of the key interventions we use as being TMS. We'll have a short Q&A from there, and then we'll roll into the role of esketamine in the treatment of TRD. If we have some time, we'll dive a little bit further into some additional kind of progressive or advanced or interventional-like services. And then we'll turn it over to Paul for case review and practical considerations, which really we hope to be an open forum conversation, and then wrap that up with additional discussion and some closing remarks. So starting off or beginning the talk, we first want to define the issue in which we're trying to treat, what we're trying to do, the care we're trying to provide. Again, I am the Chief Medical Officer for Transformations Care Network. We do have going on 40 clinics across the country, across 6 different states. I really cut my teeth in training on addiction work in West Virginia, but very early on in my postgraduate career, ended up diving very heavily into interventional services, including overseeing thousands of patients in TMS, several hundreds of patients and thousands of infusions for ketamine infusions, and now diving heavily and overseeing many numbers of Spravato treatments as well. So I do have quite a familiarity with this whole array of services, and I'm excited to present those to you tonight. But as I said, we'll first start by defining the burden of TRD and TRD itself. As we think about kind of the burden or the cause of what ultimately becomes TRD, starting with the cause of depression, for those of us in the mental health space, or those who have gone through some sort of professional schooling, would understand or know that we don't live in a vacuum. There's a broad concept of nature versus nurture. And ultimately, it comes down to a number of factors and some derivation thereof that could lead someone into the presentation of depression. And so, I don't need to read the slides to you, but the reality is those factors can include things like, clearly there's a genetic component, upwards of 30 to 40% or more. We know that there's neurochemical imbalances and challenges or dysregulation through the monoamines and other transmitter or transmission systems. We know that there have been identified brain structure abnormalities, including hippocampal volume, prefrontal cortex volumes, anterior cingulates, a lot of the areas we actually think about treating or focusing treatment in some of the interventional services we'll talk about tonight. We also know, quite honestly, and quite significantly, the issue with neuroplasticity. Again, in many of the talks I give, when we talk about the ability for medications to work, or the ability for things like TMS or Spravato to work, have to include the road system, or I use an analogy around an elevator shaft. If you get in the elevator and you push the button and there's no elevator shaft, it doesn't really matter what you do. There'll be no connectivity or very little connectivity, and thus the presentation of depression can ensue. We will look actually a little later and talk a little more about the specific factor BDNF, which I always equate to the idea of having the miracle grow for neurons. So this ability to actually create synaptogenesis and neurogenesis and arborization through the mechanism of raising BDNF levels, which, again, Dr. Leggat will talk us through later. We know that there are neuroinflammatory considerations involved. There's a number of studies going on now looking at anti-inflammatories as a mechanism for treating depression. We understand the HPA axis dysregulation plays a role in this, and we see that bore out in a variety of different HPA dysfunctions or disease states as comorbid medical conditions. We know that there are epigenetic factors, whether that's methylation, histone modification, et cetera, gene expression in general that play a role. And obviously, especially if you're a child and adolescent provider or do work with adolescents or younger, there's a strong focus on this idea of kind of early life stressors, developmental stages, and how that stress or trauma may impact the development, not just of the person, but more specifically of the brain and the pathways therein. I talked about broad strokes of nature versus nurture. Obviously, environmental factors play a role here as well. And then, as we know, comorbid medical conditions, chronic pain, strokes, heart attacks, all of those things, diabetes, cancer, all of these things play a role in impacting cortisol levels and impacting brain functionality as a whole. The mind-body connection is real, and it bears itself out in this data. So as we look then to focus a microscope on today's talk, we're really focusing on this subsection of depression, which we would define as TRD. Now, this is nationally defined. This is well established at this point. And the idea of TRD is, again, a kind of a subcategory of depression, defined by having a major depressive disorder of some sort of subtype, and then having an inadequate response to 2 or more adequately dosed antidepressants. So adequate dose and duration. This also can include the lack of tolerability to medications, and we'll talk about that here in a bit. So that would be the diagnostic criteria, having a depressive disorder and then having tried or failed or inability to tolerate 2 or more adequate antidepressants. As I said earlier, there's clearly biological factors here, the same factors that play a role in the general diagnosis or presentation of depression. There is an importance of comprehensive assessment. You want to make sure, especially if you've tried and failed a few medications, if you haven't done this already, you would want to make sure that we're looking into other potential comorbid conditions that could be causing this symptomatology or certainly exacerbating it. That could also include substance use disorders. As I said, early in my training and career, I cut my teeth on SUD, so I'm always kind of antenna up on that kind of stuff. And then clearly other psychiatric comorbidities. We know a huge subsection of the TRD population will also carry a diagnosis of depression or generalized anxiety disorder or some sort of trauma, PTSD related disorder. So the comorbidities are also very real and notable. I think for us, especially at TCN, and I would say any provider who's adopted interventional services, the idea here is that traditional medicine or current standard of care hasn't quite worked, and that we need to dive deeper, dig deeper, look at the diagnosis, but also really create an individualized treatment plan for that individual with some of the newer technologies we're going to talk to you about tonight. As we look at the impact of TRD specifically, we know that statistically speaking, from a prevalence perspective, 1 in 3 patients with a depressive diagnosis ultimately will fit into this category of TRD. We know that depression as a whole is one of the leading causes of disability by the World Health Organization from ages 15 to 44. We know there's clearly an economic impact to this that bears itself out in work productivity issues too, including absenteeism. And then finally, the risk of suicide. We know that upwards of 11% of patients who present with a major depressive disorder or episode will have had suicidal thoughts and plans within that same year. And as of the latest data point, the prevalence of major depression alone is north of 20 million US adults. And so, we're talking about several million US citizens who are having thoughts of harm. And, again, I think nearly 50,000 completed suicides in 2021. Suicide's also noted to be the leading cause of death, second leading cause of death in kind of young adults and adolescent years. So huge impact, huge burden, and frankly, not the greatest of success rates thus far. Other things to think about, there's other comorbidities, as we talked about. There's the physical health component. What we know is for every day we don't treat someone with TRD, their quality of life is going down, their life expectancy is going down, and the risk of a physical comorbid condition is going up. And that creates caregiver burnout. There's also a stigma and a social isolation involved with trying medications and giving it more time and just not seeing the results and not getting better. There's a certain learned helplessness, vicious cycle that occurs. And again, sometimes highly stigmatized. So as I said early on, for me, it's always about bringing it down to our current standard of care and then looking forward to where we need to be with time. I always kind of tongue in cheek will say, please define the definition of insanity for me. And that is, as doing the same thing and expecting different results. And so I want you to really understand the STAR-D data as we think about where we are today and why a little bit of that could be misconstrued as being insane. So when we look at the STAR-D data, largest antidepressant study of all time, over 5 years, thousands of patients through NIMH, the goal of that study was to determine what is the optimal treatment strategy for someone who presents with MDD. And it was 4-level sequential design. And if you recall the study, it's had multiple spin-offs, and there's all sorts of scales and data points to look at. And at the end of the day, as you will see on this slide, our current standard of care as defined by the STAR-D is that by the time you hand someone their third medication, again, this would be someone who would be now bucketed or defined as TRD, you will see that the chances of them achieving remission on that third medication are 16%. In that same cohort, we know that the risk of them discontinuing the medication due to side effects is 35%. Take that to the fourth step edit, and now we're at 6.9% remission rates and 41% discontinuation rates. As I said, that is a current standard of care. Given the prevalence, COVID didn't do us any favors, is really handicapping us in terms of our long-term success. And frankly, directly impacting patients at a level never before seen. So when we think about our current standard, handing someone their third medication and believing that that would give them a 16% chance of remission, or even giving them the fourth medication, we at TCN and me as a whole would tell you that our goal is to raise the current standard of care. And I'm going to start presenting to you information that hopefully will help you understand why that is and how that is. So as we look at TMS treatment for depression, what it really is it's the science around ECT and the idea of kind of re-energizing or reconnecting areas of the brain, but doing so through what I would consider a domino flick. You're able to treat a very specific area of the brain that creates the domino flick and creates the connectivity throughout the pathway, or the neural connections down through the different hippocampus, amygdala, midbrain, et cetera. It's been FDA cleared since 2008. There's been many millions of treatments to this point, and it's been found to be incredibly safe. And the response and remission rates from the original study are listed here. So 58% of patients responded, 37% of patients achieved complete remission. And then, as you'll see over time, there's actually Neurostar specifically has created a data set, an outcomes data set, and we're actually seeing superior results to that in our patients. And again, take this back to the patient with the third medication. You were giving them a 16% chance of remission. In this population, this was 37%. So an order of magnitude better. As you think about TMS for a patient, again, it's that same patient persona, the MDD, having tried 2 or more medications. There are a couple limitations here around, bipolar depression or psychotic features. There's the only absolute contraindication being ferrous metal in the within 30 centimeters of the coil itself. And then obviously treating with caution around seizure, TBI, or stroke. As I said, Neurostar's aggregated data around a kind of a real life outcomes data set. And these are the results from that data set across the country. Again, this is across several million treatments at this point. And what you'll see is, and this is a CGI scale. So this is a clinician administered scale versus a PHQ-9 or a HAM-D or a QIDS. And what you'll see here is that the clinician administered scale actually provides for response rates upwards of 83% and remission rates north of 62%. So again, truly different results compared to where we currently sit with our standard of care on handing someone their third and or fourth medication. As you'll see, based on the APA's latest guidelines, TMS slots in as a second-line treatment. You can actually go there after your first antidepressant trial. That's not a statement that your payer will pay for it, but in terms of intention to treat, safety, efficacy, it actually slots in number 2 or as a second line. We'll talk about Spravato in a similar fashion as well here next. As I said, TMS is highly beneficial. Some of the same science around ECT, just highly focal, non-invasive, very targeted, minimal side effects, some mild scalp discomfort, although scientifically similar to ECT, not ECT. and can be done outpatient. No sedation. Patient drives up, gets the treatment, drives back, 20 minutes a day, 5 days a week for 6 weeks. Covered by almost all insurances. And again, it's one of the few treatments that raise BDNF levels, which creates that neuroplasticity and promotion for synaptogenesis and neurogenesis. And with that, I'm doing my best to stay on time. So we're going to open it up for discussion around kind of the definition of TRD, the causes of depression, and the first section here, which was the original or the first treatment option, which is TMS. And I would encourage you to submit any questions. You're always welcome to submit the questions into the portal there for answer as well. Alternatively, we can have Dr. Leggat pose a question, or I could pose a question to the group as a whole. Question that might spark some interest would be if you are a mental health outpatient provider or you are an inpatient hospitalization program, what percentage of your patients do you think you see might have TRD? And again, you can answer the question through the question portal. Dr. Leggat, I might ask you, what percentage of the patients you see would you say would meet the criteria for TRD?
I think currently, since I'm seeing sort of general outpatients, but then also, patients who are seeking interventional consultation just in general, I mean, certainly over 50%.
Yeah.
Yeah.
Yeah, I mean, this is not a cut at primary care docs, but I would say that PCPs kind of take the easy ones off the top, right? They'll usually try 2 medications. That's kind of often within their comfort level or scope. So almost always by the time they've gotten to our clinic, not all the time, but a large portion of the time, they come to us having been on 3, 4, 5 medications. And if you go back to the STAR-D data, we know where we're starting with those patients in terms of success rates, right? So what I might do with a little bit of airtime then is give you guys a couple of my own kind of anecdotes here. So I mentioned earlier the idea of synaptogenesis and the concept of BDNF. And so if you actually go back, or if I were to go back, which I can, to one of my original slides here, you'll see this concept. Actually, one of NeuroStar's most famous pictures is this picture of kind of the depressed brain in a PET scan versus a non-depressed brain. And one of the things I often tell patients when I'm talking to them about why does the brain kind of not light up, or why does it light up, more importantly, I used to tell them, or still tell them, there's really 3 reasons why a brain might look underactive, or areas of the brain might look underactive. And so there's the classic area, or the classic reason, and I use the elevator analogy I alluded to earlier. So if you were to walk on an elevator, the doors don't close, you push the button, no buttons light up. That is an elevator that truly has no energy, right? So there's that area of the brain is truly underactive. It needs to be reinvigorated with energy some way. And that's kind of what people classically believe to be the case. And that's obviously where TMS and Spravato work. You'll hear about that in a minute. The other part of it, though, is there's this concept of you try to enter into the elevator and the elevator doors are going like this, and you can never get into the elevator to push a button and go to the next floor. And that's actually a situation where that area of the brain is so overactive that it's not talking to the other areas or can't talk to the other areas. And it makes the surrounding areas look underactive. So that's actually the opposite of what we traditionally think a depressed or underactive area of the brain to look like. And then the third one, and I alluded to this, is you walk into an elevator, you push the button lights up, the doors close, but there's no elevator shaft. Well, if there's no elevator shaft, that area of the brain or the areas around it will start to look underactive as well. And things like TMS and Spravato that have success rates, remission rates 3 times, 4 times that of your third or fourth medication, all of them work on 1 and 3, meaning they both use some mechanism through which they raise the energy or create energy for that area of the brain. And because of raising BDNF levels and expression of different proteins, they actually create the elevator shaft. They create the road system where you can have signaling and connectivity and communication. And it's really the ones that do both of those that create different outcomes, that create success rates of 80% plus, whether that's response and or remission rates, and do it oftentimes much more quickly than our traditional standards of care, which is medication and or psychotherapy. I think it's critically important to understand the mechanism through which we provide these standards of care and raise the standards of care. And that includes this concept of why someone might present depressed and what their brain might look like. But the reality is, just like there are many causes of depression, there are many reasons why medications or traditional care doesn't achieve the results we want them to achieve. So that's a little anecdote of mine to fill some of the time while we wait for the crowd to get interested enough to ask a question. Paul, based on what I've presented so far, what do you think a question might be that might spark some interest in the crowd or yourself as it stands?
If I was a patient, I definitely want to know the percentage of benefit. I also want to know, what if it didn't work? What are my other options? Can I go back to medications? Will the TMS maybe put me in a better spot so medications will work?
Yeah, that's a great question. So a little bit of what I've just said, which is by using things like TMS, and again, we'll talk about the same with Spravato, because you are creating the elevator shaft, there is this idea that the medications that may not have worked before may be more effective now. Now, there's that's a unique patient by patient experience, but the reality is, as I said, there's many reasons why the brain looks depressed. There's many reasons why a patient might present depressed, and to think that we can hammer and nail the situation and every person with depression will be treated this way is just not, a realistic mindset to have. The other thing to consider, and again, we won't necessarily talk about it here in the next couple of cases, but is this concept of there is clearly synergy behind neuromodulation, so things like TMS or TDCS, and the idea of something like a Spravato or a ketamine, where they are actually getting at some of the same endpoints, again, kind of option 1 and option 3 on the elevator analogy, but they're doing it through different mechanisms and present a lot of synergy with one another, both in terms of outcomes, but also in terms of how quickly we can get someone better or how we might prime the pump for someone to start feeling better. So, there's both the statistics and then the reality of kind of what all you can do, as we talked earlier about creating that unique patient experience or treatment plan for that patient. And frankly, that could include the combination of something like TMS and something like Spravato or ketamine. And there's certainly data to suggest there's both synergy and notable outcome benefits from doing that. So great question. At this point, we're still a little bit early. There are a couple slides I had in the future around some of the other advances or some of the other current interventional psych optionality. So what I might do is skip ahead to that and just go through those small handful of slides, and then we'll bring it back to Dr. Leggat here in a minute. So give me 1 second. So to lay the foundation, we've talked about TMS. We will talk about Spravato, some additional treatment options for TRD. Something that's been FDA cleared since 1997 is actually a VNS, or vagal nerve stimulator device. If you notice in the APA slide, it's actually slotted as treatment kind of 4 and beyond. It is an invasive surgery. There's a little bit of mixed bag results on this, but there's actually been a kind of a reinvigoration of this concept because it has been shown or noted to be effective in certain patient populations. So it is something I think there's more to come on. Again, it's been around actually quite a long while, but gaining some rejuvenated, renewed energy, no pun intended, here in recent years. The other kind of very classic treatment, obviously, and again, Dr. Leggat is also a specialist in this, would be ECT. So ECT has been around since very early on, different forms, cold-induced and glucose-induced and energy or, electricity-induced. The reality about ECT is it is highly effective. It's also, unfortunately, highly stigmatized and often difficult to find. So we do run into, even in very populated areas, complications with finding a provider who provides ECT, really relegated at this point mostly to hospital systems and academic centers. Although, again, highly effective, actually very effective for quite an array of psychiatric conditions as compared to things like TMS and Spravato, which have a much more narrow focus at this point. There is general anesthesia involved, so the side effects are also quite notable. And so, again, ECT is clearly a treatment option. If you look at the science, it should be slotted in. Again, really by the time you're thinking about that 4th or 5th medication for sure. And that also is in the APA recommendations. And finally, I'll put a plug in there just with the last minute of my time around the psychedelics coming down the pike. As we know, MDMA is actually in pretty advanced stages of research, as is psilocybin. It's likely that we will see one of these FDA cleared and approved in the very near future. And there's just, as this slide says, a growing body of literature and evidence around that the efficacy associated with psychedelics, and frankly, not only for depression, but anxiety and PTSD and a number of conditions where we've really lost our way in terms of benefit and efficacy in our current patient population with our current treatment options. So certainly a lot of hope in the idea of psychedelics in the future, a big combination or capability of combining the procedural medical side with the psychotherapy side, and just a lot of opportunity coming down the pike. So excited for what may come of it. Still a little early to tell kind of in totality what we'll see. But with that, I'm going to swing on back, and I apologize for the back and forth here. But I will turn it over to Dr. Leggat, and with that, good luck.
Okay. So I'm Dr. Merrideth Leggat. Dr. Wakim, I actually had a couple of kind of neat thoughts as you were talking. One was you had mentioned sort of the overactive elevator door. And I think TMS can actually address that too by normalizing connections between the subgenual cortex and the dorsolateral prefrontal cortex and sort of those normalizing elements of the default mode network. I had a couple of other thoughts too, just in terms of looking at vagus nerve stimulation. It is obviously an invasive procedure, but I know some providers have used vagus nerve stimulation in patients who've had ECT, kind of as a means to maybe prevent the need for maintenance ECT. So you treat where there's enough time for the vagus nerve stimulator to take over, and then it may prevent that need for maintenance ECT. And then, Paul, you had mentioned this idea of, after I have TMS or Spravato, are my medications going to potentially work better? And I think that ECT, for instance, if we're thinking about maintaining remission post-ECT, we're thinking about like nortriptyline or lithium or Effexor use. And it'll be cool when we can kind of get to a point in our use of TMS and Spravato, maybe where we're saying, okay, well, once you're done with your interventional course, here are some things that, you might be able to take that would sort of allow you to maintain your response or your remission. So those are just some thoughts I had. We're going to transition now to talking about the role of esketamine and the treatment of treatment-resistant depression. In this portion of the talk, we're going to review the mechanism of action of esketamine. We'll review briefly the administration, potential side effects, and contraindications. We'll discuss the important phase 3 Transform 1, 2, and 3 studies. And then we will fast forward to our 4-year interim analysis data. So our long-term open label data regarding Spravato use, which falls under the category of Sustain 3, which is an ongoing study. And then we're going to end by talking about some clinical and practical implications with respect to Spravato. So Spravato is the brand name for esketamine. Spravato was developed by Janssen Pharmaceuticals. It is the S enantiomer of racemic ketamine. So we have the S and the R, and Spravato is the S enantiomer. And esketamine is a non-selective, non-competitive antagonist of the N-methyl-D-aspartate or NMDA receptor, which is an ionotropic glutamate receptor. It's important to point out that the S enantiomer has a 4-fold higher affinity for the NMDA receptor than the R enantiomer. So it packs a little bit more of a punch than the R, potentially. As far as FDA approval, Spravato was FDA approved in 2019 for use in conjunction with an oral antidepressant for the treatment of adults with treatment-resistant depression. And again, specifically with respect to the esketamine trials, and referencing what Dr. Wakim had said, treatment-resistant depression in this context includes patients with major depressive disorder, who have had an inadequate response to 2 or more oral antidepressants. I do want to mention that Spravato was FDA approved in 2020 for use in conjunction with an oral antidepressant to treat depressive symptoms in adults with MDD with acute SI. This comes into play where patients who are given Spravato can have a decrease in symptoms within a period of 24 hours, although that has not been translated just yet in the data in terms of actually decreasing suicidal behaviors. So we'll focus in this portion of the talk on the use of esketamine in treatment-resistant depression. In terms of our proposed mechanism of action for Spravato, it's quite unique. It does not involve monoamine neurotransmitters. And the thought is that glutamate is the major excitatory neurotransmitter of the CNS. And current evidence points to altered glutamate signaling in major depressive disorder. Esketamine preferentially blocks the NMDA receptors on inhibitory GABAergic interneurons. And when you inhibit an inhibitory neuron, you get an excitatory surge. So in this case, we get an increase in presynaptic release of glutamate. And then that surge in glutamate then that release activates AMPA receptors and then stimulates the production of BDNF. And then BDNF expression and activation of what we call the mammalian target of rapamycin or mTOR. Both of those together improve plasticity via increased neuronal dendritic growth and also improve synaptogenesis. And while preparing this talk, I found this very nice graph in a review article of Transform 1 through 3 and Sustain 1 and 2, and sort of summarizes blocking of NMDA, surging glutamate, activating AMPA, increased signaling, which causes BDNF release, and mTOR activation, which again accounts for dendritic growth and improves synaptogenesis. The really cool thing about Spravato and also IV ketamine is that it's thought that both of these, or esketamine, stimulates BDNF and mTOR in a way that's more direct than oral antidepressants. And just generally speaking, the stimulation is thought to contribute to both the rapid onset of antidepressant effect and also the sustained effect. So that being different from oral antidepressants, and sort of referencing something that Dr. Wakim had said in his talk, that rapidity of response, so people getting an improvement of symptoms within 24 hours and then continuing to get improvement over the course of a few weeks, is so essential because with STAR-D, we know that with sequential failures of monoamine-based antidepressants, we get increased risk of relapse, intolerability, and suicidality. So I think it makes Spravato particularly relevant. Just in terms of treatment administration, so Spravato is an intranasal spray that's administered non-invasively. Patients administer it and then they're observed for a period of 2 hours. It's intended to be used in conjunction with an oral antidepressant. Typically, patients for treatment-resistant depression undergo a twice-weekly induction phase, followed by a once-weekly phase of administration. And Spravato is administered as part of a risk evaluation and mitigation strategy, or REMS program, where providers, DEAs, are linked to locations and distribution of the medication. Patients get the medication in an identified center, and they're monitored over that period of 2 hours for onset and then resolution of sedation and dissociation. And they're also monitored at 0, 40, and 120 minutes to look at impact on blood pressure. Those are some of the common side effects. And it's also part of the REMS program because of this potential as a controlled substance for misuse and abuse. There are some contraindications to Spravato. Looking over here, any type of aneurysmal vascular disease, and also arteriovenous malformation, any history of intracerebral hemorrhage or hypersensitivity to ketamine or esketamine. I would also add anyone with significant cardiovascular or cerebrovascular disease, patients with poorly controlled hypertension, although if you have someone who has poorly controlled blood pressures, you can proactively treat those and then put them in a situation where they would be medically safe to continue with treatments. And then just one word about substance use disorders. In the Transform 1, 2, and 3 studies, in order to be included, patients had to have not been active in their substance use for 6 months. So it's just something to consider. Okay, so Transform 1, 2, and 3 marked 3 of the 5 phase 3 Spravato studies that contributed to FDA approval of intranasal esketamine. Transform 1, 2, and 3 were randomized, multi-center, double-blind, active controlled studies that included adults with moderate to severe depression and non-response to greater than or equal to 2 antidepressants in the current depression episode. Patients were evaluated over a period of 4 weeks, with the primary efficacy endpoints in all of the studies being changed from baseline to day 28 MADRS scores performed by blinded remote raters. Transform 1 included 346 patients who were randomized to twice weekly fixed dose esketamine for 4 weeks either 56 or 84 milligrams plus a newly initiated open label oral antidepressant. Interestingly, those patients were 18 to 64, and the mean duration of the current episode of depression in those patients was 4 years. With Transform 2, this study was conducted in 39 outpatient referral centers, and patients were switched from an ineffective antidepressant to flexibly dosed ketamine and a new antidepressant versus a new antidepressant and placebo nasal spray. And again, patients were 18 to 64 years of age. And in Transform 3, we're looking at our older population where patients were randomized. So patients greater than or equal to 65 years of age, randomized to flexibly dosed twice weekly esketamine, which in this particular situation was 28, 56, or 84 milligrams. And there was also a pre-planned analysis to look at patients between 65 and 74, and then those greater than 75 years of age. So looking at the results from Transform 1, statistical significance was not achieved with the esketamine 84 milligram in combination with the antidepressant in comparison with the antidepressant placebo group, but the treatment effect was thought to exceed what has been considered clinically meaningful for approved antidepressants versus placebo in medication trials, meaning the MADRS scores changes were more significant than would typically be seen in medication trials. And the improvement from baseline in MADRS scores declined over the 4 weeks. Response and remission rates were maintained over the course. And essentially, this study also showed that esketamine was safe and tolerable. Transform 2 is where we get to some of the more meat of our data. The change in MADRS score with esketamine plus antidepressant was significantly greater than with antidepressant plus placebo at day 28. There was clinically meaningful improvement at earlier points as well. You can see here the 5 most common adverse events, and those typically resolve by about an hour and a half into treatment. And then with Transform 3, again, the results were not statistically significant, but still clinically relevant. And in addition to improvement in MADRS scores, the CGIS, PHQ-9, and SHE and disability scores showed changes that were consistent in comparison with younger populations. So, and the comorbidities of those patients did not appear to influence the response rate, and adverse event rates were not greater than seen with younger patients. I picked a few slides from Transform 2 just to, I think, show the clinical applicability of the information. So in Transform 2, the average age was 45. The current episode of depression was over 2 years. Average MADRS was 37. Most patients were women. Specifically, over 30% of patients had been on greater than or equal to 3 medications. And I think that this just speaks to how relevant the data is when we're talking about our patient population. You can see here the decrease in the MADRS score even at day 1, which continues over the 4 weeks. In terms of response and remission rates, we see at week 4, 52% of Spravato plus an oral antidepressant achieved remission versus 31% with the placebo group, and then comparable improvements in responses. We have here the most commonly encountered side effects. Other important things to point out in Transform 2, patients had an improvement in GAD-7 scores. Patients had improvement in suicidal ideation. Again, the adverse events were considered to be of mild to moderate severity in 90% of patients. So the treatments were very well tolerated. Now, looking at some of this data as it plays out over the long term, we have Sustain 1 and 2. Sustain 2 was open label study collecting data over 1 year. Again, The Spravato HCP website lists ongoing data from Sustain 3. Again, patients are enrolled and participate in an induction phase and then in an optimization and maintenance phase. And we can see that there were no new signals with respect to adverse events over this open label 4-year period, and that included over 1,000 patients. There was no increased risk of substance use. There was no increased risk of interstitial cystitis. And importantly, there was no long-term cognitive impairment. And that was tested using the cognitive state battery and Hopkins verbal learning test. And you can see here also, yes, this is open label data, but 70% of these patients had 30 months of Spravato. And with weekly or every other week maintenance, patients are still maintaining their MADRS and PHQ-9 scores. And it's not seen here, but the 4-year data for Sheehan disability scales is very similar. So just summarizing, and I know I'm just slightly over time, Spravato represents medication with a novel mechanism of action, working not through monoamines, but through BDNF and mTOR to increase synaptic plasticity and neurogenesis. We have an easy administration intranasally, and also potentially we're targeting multiple pathways using glutamate enhancer and also medications that patients are already taking. Just a few clinical implications and points by way of summary. These treatments are well tolerated. Dropout rates are on the order of about 7% in the 5% in both the short and long-term data. And again, Sustain 3 not showing an increase in adverse events. Transform 2 demonstrates, all of the studies look very good from a data standpoint, but in terms of statistical significance, Transform 2 really shows proven efficacy of flexibly dosed Spravato and an antidepressant over placebo. Patients are maintaining those responses at 4 weeks and through the 4-year mark. In terms of looking at older patients, the responses are slightly less robust, but still a worthwhile treatment. And some of that may have had to do with the study design. So certainly worth considering in your older patients. And thinking about these studies, the placebo responses are relatively high. However, we're comparing to placebo plus an antidepressant as opposed to just a placebo. And of course, Spravato plus an antidepressant is going to be superior, particularly at levels 3 and 4 when comparing to STAR-D. Just a point that these results are generalizable to our patient population. And patients on Spravato not only do better from a mood standpoint, but they function better in their daily lives. So with that, I'm not sure if we're handing things back to Wakim or if we're turning things over to Paul.
I will first take myself off mute, and then I will take it for the moment. So, Dr. Leggat, thank you for that section of the presentation. Incredibly interesting, just around, what, for me, when I've seen this, we've also done a lot of work with IV ketamine, and, really that the immediacy through which this treatment works. I can't highlight that enough. I know that I mentioned it earlier, but when we think about severe recurrent resistant depression, we really haven't to this point in time had a treatment that worked to that level of rapidity. And the fact that you might ask someone who is severely depressed to go home and wait another 4, 6, 8, 10, 12 weeks to start feeling better, to me is where we as a profession have spent far too much time leaving well enough alone, as you've probably heard me talk about that in the past. Just because we had to leave well enough alone because we didn't have options, right? So I guess maybe along those lines, what have you seen, clinically, anecdotally, just around how quickly Spravato's maybe help someone that just had lost hope otherwise?
Yeah, I mean, gosh, I think two thoughts. I don't think I could say, enough that a significant portion of patients are going to have a response within 24 hours. And certainly, clinically as a standard of care, you're seeing those patients, twice weekly prior to their treatments. And you really do kind of get to appreciate that they're feeling better soon. And I can think of one clinical case recently where the patient just really had completely lost hope. And it wasn't even so much that she was suicidal, it was just sort of this nihilistic perspective that she had on existence. And that changed within 3 or 4 treatments. And I think another way to look at Spravato, and then of course IV ketamine as a treatment option, is that because patients will get a response so quickly, these are also, we should look at them as tools to prevent hospitalization, and to really impact suicidality. And perhaps if you can support patients in an outpatient setting, giving them these treatments which act quickly, you've done more than sort of that typical model where we send them to the hospital for safety's sake and they have some improvement but are started on an oral medication and then they get discharged. I think incorporating Spravato and IV ketamine just clinically makes so much sense.
Yeah, I know that we've engaged many payers and many community partners around the idea of using something like Spravato and IV ketamine. We didn't make any slides specific to that tonight, but as you've already said, racemic ketamine as compared to the S enantiomer. But I know I've been on many conversations with payers and community partners, hospital systems, around the idea of using something like this as both an ED diversion strategy, because ultimately, HEDIS scores and readmission rates matter. The patient matters, right? And getting them well and be able to do that within 24 hours or extremely quickly, as compared to, again, leaving well enough alone or standard of care as usual or care as usual, which we know isn't making a dent in our current, condition state, which, as I said earlier, COVID didn't do us any favors and actually has raised the depressive symptomatology threefold since just before COVID. So we were doing a pretty poor job at getting people better and keeping them better before COVID. And now there's just so much more to chew through and very difficult. So with that, we have a few minutes left. So until we turn it over to our very esteemed colleague, Paul, to walk us through some case review and practical considerations for the use of Spravato. But if you have any questions, by all means, please pop them into the chat there. I'm happy to present them. I will say one question did come through in the middle of the last section there, and that was the idea of using TMS in what I would call the seasoned stage of life. So over the age of 65. Merrideth, maybe Dr. Leggat, I apologize. Maybe I'll throw that to you. What is your experience with TMS over the age of 65? Can you speak to, you might not have any specific data points in that subsection, but just, Medicare covers it. It has been shown to be effective. I don't remember the upper bound for TMS from an age perspective, but do you want to speak to that a little bit?
I mean, I think I would say yes.
Yeah.
TMS, yes, in the older population. Historically, those patients don't respond as well to medications, which is why ECT, is something that we've always thought about in the older population. They tend to have more side effects with medications and different things like that. So I think that the more I practice interventional psychiatry, the more I'm thinking about TMS for older patients. I I think if you looked at like the large Neurostar registry that came out in 2020, it really showed that older patients have an equal response to younger patients, and age is not, an exclusion criteria. In fact, we should, as with everyone, we should be moving it, closer to at least second or third line, the only other thing I would add on that is I think that even though the Neurostar registry said that age was not really a factor, my kind of anecdotal experience is sometimes older patients just need more pulses. So kind of the way that I would approach ECT, where if someone is on an index course of 6 to 12, but they're still getting improvement between treatments 11 and 12, I'm going to continue to treat them before I transition them to continuation or maintenance. I have a patient right now who's elderly, and she's, on 34, 35 and continuing to get benefits. So we're going to do, 10 or 15 more treatments, because I just think that clinically, I don't know the data supports that 100%, but clinically it makes sense to me.
Yeah, I've done something very similar over many years now, so I agree with that. Mm-hmm. All right. Well, next up, we have Paul Ruberg to talk to us about the case review and practical considerations for the use of Spravato. Paul, I'll turn it over to you.
All right. Thank you, Dr. Wakim.
Yeah.
I have to thank Dr. Wakim and Dr. Leggat for going over the nitty-gritty before getting to the case review, so thank you for that. So as Dr. Wakim said, we're moving into the case reviews. So our first patient case review, as you can see, it's a 25-year-old male. Now, this patient has tried a number of SSRIs, SNRIs, and just going from one to the next, not getting too much benefit or no benefits or even adverse side effects to the medications. As you can see, his symptoms prior to his Spravato treatment, just lethargy, minimal exercise. The patient used to be an avid runner, doing it very frequently during the week. And when his depressive symptoms kicked in, he was barely running, maybe getting out once a week. He also had some low initiative. The patient told me that he had these little mountains of laundry that he just neglected over time, and they were just building up, and that low initiative just filtered into other areas of his life. He sort of felt hopeless, didn't really have any direction going on. He was considering going back to school, couldn't make a decision, so it was just like an aimless approach. And the patient was using weed, as you can see, 0.5 grams per time. He used it intermittently. Now, the patient was informed that the weed use and Spravato, it's not an absolute contraindication, though I made him aware that if he continues to use it, we don't know how it interacts with Spravato, and that's been told to any patient that comes our way. So just make them aware of that concomitant use. Now, as you can see, his PHQ and MADRS were fairly high. And this is pretty typical for a lot of the patients presenting through for Spravato treatment. They are severely depressed and they've gone through multiple medications without relief. Now, the benefits of this patient, so after 20 sessions, as you can see, he had a remarkable turnaround. He had a new job, moved to a new apartment, girlfriend, those piles of laundry, non-existent. So he had more initiative to get up and go and do activities. And he happily told me that he got accepted into film school someplace in Northern Virginia. He was super pleased about that. And he was back to running on a regular basis. I think those are all positive and show how it was a really good turnaround from his multiple medication failures with the SSRIs and SNRIs. And as you can see, he stopped using weed, didn't need that anymore. and the PHQ in the MADRS came down remarkably. So this patient was super pleased after his treatment, and this is a remarkable turnaround for him. Moving on to the second patient. So now we have a female, and this patient was in a similar starting position to the first case. They had tried multiple SSRIs, SNRIs, and this patient had been going on these medications for 3 to 5 years. The patient was also given adjunctive measures such as lithium, maybe TMS, buspirone, and none of those really took effect for the patient. So she was seeking that next step, and she decided to try Spravato. Now you can see with this patient, similar symptoms prior to the first case review. Low motivation, no interest in doing their hobbies. And also she had no desire to exercise. This is one thing that she had done in her past on a regular basis. And also she was not driving a vehicle, and this was due to choice. She just didn't have that energy to put in the concentration that's required to drive. So her family members, her spouse were driving her everywhere. And also she wasn't working. And she really wanted to get back to work. She loved what she was doing. She had a lot of patient or customer interaction, and she wanted to return to that, but just couldn't with all her depressive symptoms. And she was looking for an outlet to get benefit. And just as with the first patient, MADRS is still on the higher side, 37, so definitely very depressed. I can tell you this patient, when she first presented, she was very skeptical about starting Spravato. She had failed numerous medications and just didn't have that hope that something was going to give her the benefit that she was hoping for. And as we move on to the positive outcome for this patient, she had a tremendous turnaround just after 4 treatments. Within that short time frame, she had the desire to exercise. I believe she had just had the thoughts to exercise. She wasn't taking action to do it yet, but going from not wanting to wanting to, that was a huge change for her. And per her words, like having life for herself. Before Spravato treatments, she just didn't feel like there was any reason to keep going on. She did have some passive SI on an infrequent basis. And now, just after 4 treatments, she really had that invigorated approach, like she had life in herself. And she also had that desire to drive. This popped up, and she was very happy because it made her think, like, this is a step in the right direction to her getting back to work, which she really wanted to do. And as you can see, the increased socialization. I remember her husband telling me that when they were around their grandchildren, she was more playful. She would get down on the floor with them. Prior to the Spravato treatments, she didn't interact too much. She would sit on the chair, sort of be that person in the background, just watching everything, but she wasn't engaged in what was going on. And as you can see, she was engaged just after 4 treatments. And her PHQ-9 came to a 5, didn't get a MADRS at that time, though after 9 treatment sessions, you can see her MADRS came down and her PHQ was 3. So she was still making some good progress. And at this point, she was driving solo. She took some steps to get there. She had to drive with one of her relatives or husband just to get a comfortable feeling for driving again, though she was able to drive without a passenger and she felt comfortable doing that. One thing she told me, and this was echoed by the husband, before TV or any sort of music or ambient noise was just there to occupy time, just be a distraction. But now she was actually watching TV. She was listening to music, and the husband noticed this because this is something that they had done in the past. And he was like, wow, this is a super great change for her. So again, just in her benefit profile, like she was just more engaged with what was going on in her life. And she has continued treatments past the 9 and still continues to get benefit. So she is loving it. She has cut down her treatment frequency. She is in the maintenance phase and she's getting every other week treatments. But again, she is maintaining the benefit she got. And I'm hoping that she gets more treatments. Now moving to patient 3. Here we have a 31-year-old female. And just as it was for the first 2 case reviews, this patient had tried multiple SSRIs, SNRIs, done the adjunctive measures. She's also done TMS. I believe this patient did get a little bit of benefit from TMS. It wasn't to the degree that she was hoped for, nor did it last as long as she had anticipated. And this patient had gone through the medications, I believe about 3+ years. So again, she's getting to a point, try one, it fails, try another one, and just getting frustrated at that approach. So her symptoms prior to Spravato, she was crying on a regular basis. She had low to no appetite. Her partner had to remind her to eat, or she could go an entire day without consuming food. The patient knew that wasn't the right thing to do. She just could not bring it to herself to actually go make a meal, go out to get food. So that was a bit concerning. And this patient, she told me, had daily passive SI. There was no plan or intent, though she just had that feeling like, what's the reason to live for life? She couldn't find it. The patient admitted to poor focus concentration that was present in her work life and her personal life. And just as similar to the first patient, the ADLs required assistance. So she had things piling up, possibly laundry, other tasks that weren't being addressed. And sometimes her partner had to do that for her. Now with this patient, again, they were using weed on a regular basis. As you can see, 1 to 1.5 grams a day. Again, this was to calm her down, to help her with sleep. This was the only thing that was sort of working to manage some of her symptoms before she initiated Spravato. And again, just with any patient that is using weed or marijuana or THC, we let them know that, yes, you can continue to use this, but just be aware that it may interact in a adverse, unfavorable way with Spravato. And as you can see, her MADRS clinician, 40. So again, very depressed. And as you can see, a reoccurring theme is popping up that a lot of the patients are getting some good benefit from Spravato. So she had received 25 treatments. She got a couple more after that. And this was a great change for her. No crying. I was super happy that she was eating. She had the urge to eat, and she would seek food versus needing reminders. This passive suicidal thoughts, they vanished. She was back to doing her daily activities without assistance, which was great. And one thing that she was very pleased with, in her past, she used to read on a regular basis. And now she was reading for pleasure versus reading because it was required of her job. And she was able to sustain focus while reading lengthy pieces of material. And this patient, just as the first patient, they stopped using weed. They didn't see any reason to use it. It wasn't giving them benefit because they got a tremendous turnaround from Spravato. And this patient, as you can see from the scores, PHQ of 0. That doesn't always happen. This patient just had a super positive turnaround from Spravato, and MADRS clinician was a 5. So this patient was just very pleased. And I believe at one of her sessions, she told me that she feels normal. Prior to the Spravato, she just didn't feel right, felt that she should be doing something different or feeling something different. And just from the benefits here, she was more engaged. She also felt equipped to handle what life was throwing her way. That sentiment has popped up with some other patients that they just told me that whatever life throws their way, they can just let it roll off their shoulders or reframe what's going on so they don't have the same reaction as they did in the past prior to Spravato. And just some closing remarks here, just some considerations to be aware of. As Dr. Leggat went over, there's always exclusion factors, criteria. As she mentioned, you can't be psychotic, can't have the cardiovascular issues, any recent substance/drug abuse. There will be reasons to not pursue Spravato. Pregnancy is another one. The second point about life circumstances and outside factors, make sure the patients are aware that if they hate their job and they're going to that job 5 or 6 days a week, that's got to be addressed by the patient. The Spravato may help with some of the symptoms, but keep in mind you're going to that job multiple days out of the week, and depending on where you are in the Spravato protocol, you could be getting treatment 1 or 2 times a week. And you've got to weigh that pros and cons. I've had a patient that they did not like their job, and I noticed a trend that on the holidays or when they took vacation, they were a lot better, felt happier, felt motivated, less anxious. But once work returned, their anxiety set back in, they were depressed, sad. And this, you have to be frank with the patient and let them know that this is a limitation that we've got to address. And last point is educating the patient about the treatment process. I've had a lot of patients come through and they are very scared because of the psychedelic medication. How are they going to react? They've read forums, Reddit, saying people are like talking to their grandparents. You've just got to give them some comfort and saying, yes, this treatment is a psychedelic. It's in a controlled environment. We will do our best to make sure everything works out well, and just give them that reassurance that this is something new. You've tried the other medications or adjunctive measures, and you're not getting the benefit. Let's try this and see how it works out. So I think that comfort factor really goes a huge way towards the patients, because this is something new, and that newness can be a little bit frightening. And I believe we're pretty good on time. And now we're at the discussion, and I believe I will pass it back to Dr. Wakim.
Yeah. Thank you very much, Paul. I appreciate that. Great job presenting those cases. So to kind of get the juices flowing for this section of the Q&A, maybe I'll ask you, because something I noticed in your cases specifically, we do say, obviously, Dr. Leggat mentioned this earlier around, in the studies themselves, they were excluded around Spravato if they were in active substance use, or didn't at least have 6 months of clean and sober time or abstinence. Several of the 2 of the 3 cases you presented tonight had presented cases in which individuals, again, this is not a political statement, but they were actively using cannabis as part of their self-medication and care. And, obviously what you're able to show is, number one, on the front end, telling a patient, hey, we don't know what this means because, it wasn't studied in individuals who were using marijuana. However, what's pretty evident is, in spite of that, it worked, and it still worked pretty quickly, and it seemed to be staying working. And the other thing I noticed is that their self-medicated, cannabis use reduced or eliminated. So maybe I'll just pose a question. What have you seen in your region? And we have 6 regions across the country, and there's obviously varying degrees of kind of legality and use across those different markets. So what have you seen in your market? And clearly you don't shy away from using Spravato in patients with a cannabis use history or, current cannabis use. But can you give us a little bit more on that, or how do you view that, or how common is that?
There have been a number of patients that have used weed on an intermittent or regular basis. My attending, Dr. Baru, when we go over the patients, I check with him about the safety protocol and get his opinion. And we came to the agreement that if the patient is made aware that there is increasing use and acceptance of marijuana in any shape or form, that we don't want to withhold treatment from them. We just want to make them aware and keep them apprised of these are the facts that we know at this point. And should you wish to continue with the treatment, you are acknowledging some of these facts. So we document that. As for the use in the DMV area, it's hard for me to say. I think some people, it's just their friends are using it. They read a forum that's something else. Somebody else is getting benefits, so why don't I try it?
So yeah, I mean, not uncommon and not a reason not to treat, I think, is the pretty important piece there. And frankly, clearly still getting results, although anecdotally, in that patient population. So going back to the practical considerations, what else maybe wasn't on the slide that you feel like is a common consideration that you have to take account of on a day-to-day basis? You oversee a lot of Spravato treatments every week. And so what other curveballs come your way that are might be nuggets of information for the audience?
Aside from dealing with the insurances, which can be a little bit of a pain,
Yeah,
I think that's probably the biggest thing, because unfortunately the insurance companies, they are the one approving the treatment. So you want to make sure that you capture the requirements of the insurances in your area. Because the best thing I found is if you know what they want up front, you can address it with the patient during the eval. And then also it reduces your chances of getting a denial and going through an appeal. I think that's a great step to take. Just evaluate what the insurances need in your area. Sometimes the driving can be a problem because a lot of patients, they don't realize that because of the side effects, the dissociation and sedation, you're essentially an impaired driver. So you can't drive home. And that does give a lot of patients pause before they consider doing this. So just make sure that is very well established.
Yeah. Okay. The other practical consideration I hear a lot about, both within our clinics and outside of our clinics, has to do with just the referral process. Or, hey, we have a lot of, as you know, you have to be a REMS treatment center and certified to provide the treatment itself. And we have a huge unmet need. We've established that. And so there's a number of providers in the community, be that hospital systems or primary care doctors' offices, or even other mental health practices, therapy groups, group practices, psychiatry practices, who might be looking to refer, or might want a better understanding of what that process looks like. And I get a lot of concerns around, kind of sending someone into a vacuum and not really hearing anything back. Or there's obviously a lot of concerns I've heard over the years around us taking their patient as an example. So how do you talk to the patient about that? How do you talk to other providers about that? What are some considerations you've seen with regard to that?
Yeah, so the poaching of a patient, we're not going to do that. The provider, if we talk to them, just let them know it's a service that we're offering for your patient to help them out. They still remain your patient for the medication management, and we can provide updates of how the patient is doing, their session counts, and send a fax or whatever medium they would prefer, just to keep that up to date. And I also tell the patients too, if they ask, like, does this mean I'm transferring care? No, it just means that we are offering a service and you're still going back to your medication management provider. Someone told me a good example. Just say if your kid is seeing their dentist, the dentist can't do orthodontics. You were just referring them out for a service, but they still come back to the dentist for the regular care. If you think of it that way.
Yeah, no, that's actually, my wife's a dentist, so I very much understand that analogy. I guess before we wrap it up tonight, either Paul, you, or Dr. Leggat, any final words, any other careful considerations or comments you'd like to make about TRD, TMS, Spravato, or the cases or considerations therein?
I have one comment. With the interventional services, don't wait too long to start these. you don't want patients to go through 10 different medication fails before they get here, because it might be hard to encourage them to try a new treatment. If you can plant that seed early for TMS or Spravato, I think it goes a long way. So when they do reach that criteria threshold, it's an easier topic to broach.
Yeah, that's a great point. Yeah.
Yeah, I was going to say exactly the same thing. And Dr. Wakim, I'll just use your words, viewing sort of, treatment of depression through a lens of urgency. I think that requires a paradigm shift in terms of how we think about depression, not just psychiatrists, but kind of all providers. Because, there's just no reason for patients to be suffering. And we really want to be in a position to offer them what is the standard of care, which would be to get these treatments sooner. And, I think it's really interesting when you look at the sort of statistical modeling studies of patients, for instance, who get TMS first line as opposed to a medication, or second line after a first failed medication, and just emphasizing to everyone that, it seems like a lot to offer it out of the gates, but the reality is that they cost the system less over time when you treat them aggressively up front, and they have a better long-term quality of life. So I think that, again, kind of looking at things through that lens of urgency, and like Paul said, thinking about these treatments much earlier on is really, I think, a key takeaway point.
Yeah, I couldn't agree with either of you any more than you've already stated, which is we have to do better at treating this with a level of urgency and respect that the patient deserves. And we frankly have done our patients a disservice to not be aware of things like TMS, to not be, whether you're aware or adopting, or at least able to refer for something like Spravato or TMS. And we know now statistically where that leaves that patient. And we have to be better if we want to make a dent in the condition state that we're currently in. So there's absolutely a level of urgency here. There's absolutely a level of patient suffering that we often just fall victim to, as, again, this idea of leave well enough alone, because frankly, until recently, we ourselves as providers haven't felt capable of doing better. And the reality is we can, and here's the data and the treatment options to do that. So I really appreciate both of you taking your time out tonight to, impart wisdom, critically important to help the audience understand both your perspective, but also the science and data behind it. And, again, I'm super excited to be surrounded by such great people to help us as a company elevate our standard of care. In order to do that, you have to have folks like yourself who are willing to both embrace it and, discuss it and take their time to help not just patients, but other providers understand what options are and what they should be. So thank you for your time, Paul and Dr. Leggat. I really appreciate it. Having said all that, I have nothing really more to add. There are not presently any additional questions. We do have a few minutes, or I think we're actually maybe a few minutes over. So I will turn it back over to Mel, who will ride us out.
All right. Well, thank you. Thank you, Dr. Wakim. And thank you, everyone. What a great, awesome program it was tonight. Fantastic job. So thank you. Thank you, Dr. Wakim, Dr. Leggat, Mr. Ruberg. Thank you to Janssen again for supporting this HCPLive State of the Science Summit in Psychiatry. And I'd also like to thank our viewers tonight for spending your evening learning from the experts with HCPLive. Just a quick reminder, complete the questionnaire that you will receive in your email at the conclusion of this program. And remember to hit send when you finish to receive your $50 Grubhub credit. And Christina has the wheel up. So Christina, will you give it a spin for our first winner? And the winner of our first $150 Visa gift card is Jack Tyson. Congratulations, Jack Tyson. And our second winner is Emmanuel Ronald. So congratulations, Emmanuel. Again, thank you to everyone for attending this evening, and I hope you have a good evening. Good night, everyone.